Yeah, thank you. No, thank you so much, Dr. Richenhausen. We do have a few minutes for the questions. I see there are questions for, first for Dr. Wells. Is can anakinra be used in fires?
Yes, thank you for the question. So I did not get into the full detail of how we treated that particular patient, but anakinra was started actually on day 1 of diagnosis. You make the diagnosis when you fail to wean off the anesthetics. And so that was it's now incorporated as part of the suggestion for protocols. We helped publish a retrospective study of 25 patients treated with anakinra that showed, really favorable side effect profile and some hint of shorter duration of ICU stays and hospitalizations. But I think it's very hard to tease that out given everything that patients with virus get.
You're muted.
Adriana, you're on mute.
Oh, I'm so sorry. Yes. Thank you. Dr. Vanderveer, I was wondering, what is about the percentage of patients with a phenotype of AGS who don't have a genetic diagnosis?
That's a great question. In our group, it's about 10% of children who don't have a specific molecular diagnosis. Some of the molecular diagnoses of AGS are particularly hard to make. For example, RNUN7-1 is a non-coding gene and isn't offered, easily commercially. So I think it's important to understand also that in some places it may be higher because you're not actually able to test easily for all the genes, and not all the genes yet are being addressed on panels. But I think above and beyond even that, I think there's at least 10 to 15% of children with AGS-like phenotypes who don't have a specific molecular diagnosis. It's that situation is made even more confusing because I think that there are other situations, as some of the cases that we're presenting today, that can give you significant white matter abnormalities and things in elevations of neopterin, as can be seen in clinical testing. And so there's a lot of overlap disorders with chronic viral meningoencephalitis, because you have a like chronic enterovirus, because you actually have an underlying genetic disorder, but not AGS, that compromises your immune system and makes you vulnerable to chronic encephalitis, as well as other immune-mediated disorders. So I think we still have a lot to understand about sort of some of those overlap features of things that can give you an appearance of primary interferonopathy. And I think, as people have been talking about today, that just because you might not have a full understanding of the molecular picture and etiology, that doesn't mean that you can't start to try to think, at least on a one-on-one basis, applying some of these novel personalized drugs that target specific pathways, to those patients. So we have also, in some cases, after a lot of thought, treated kids with evidence of interferonopathies with Janus kinase inhibition to try to rescue neurologic phenotypes, even if we didn't have a full understanding of the molecular cause of that presentation.
I see. Thank you so much. Yeah, we need to wrap up now for the next session.